Let me just try one thing here. Sorry. Little doodle. And thank you to all the patients and families for joining on this evening. So we're going to talk about managing heart failure in ARVC. And our learning objectives this evening are going to be to define heart failure and cardiomyopathy, understand heart failure in the context of ARVC, describe signs and symptoms, and review our treatment strategies. So I always like to put this in the context of a patient, of all of you. And so let's start with a patient. So we have a 20-year-old college swimmer who at practice experienced trouble breathing and then vomited. Upon emergency evaluation, she was noted to be in a ventricular arrhythmia and required an external shock. She then underwent evaluation, and her heart imaging actually showed an enlarged and weakened right ventricle. And this story probably doesn't fall far from home for many of you. This was characteristic imaging on an MRI. This is her right ventricle. You can see some enhancement in the muscle wall and that it's enlarged. And so as she continued through her diagnostic journey, she was formally diagnosed with ARVC the next year. But within 5 years, had recurrent ventricular tachycardias and 3 ablations. But despite that, went on to have a successful pregnancy and work full-time as a teacher. Then 10 years later, at age 36, she started having problems with abdominal bloating, decreased energy, increased fatigue, and shortness of breath. So I'll have you keep this story in mind as we talk through. And I want to start with a few definitions. So arrhythmogenic right ventricular cardiomyopathy. As many recall, the terminology used to be dysplasia and has switched over to cardiomyopathy. So what does cardiomyopathy mean? So literally it means cardio, heart, myos for muscle, and pathy, so weakness or disease. So a weak heart muscle. And there are multiple causes. So most commonly, patients who have heart attacks or coronary artery disease can get weakening of the heart muscle because there's an area of the heart that doesn't get enough oxygen or blood flow during the time of a heart attack. There can be genetic conditions. We're all here because of that. There can be infiltrative diseases. So actually abnormal proteins or other things that can deposit in the heart. Infections. So myocarditis, as we know, is a cause of sudden death as well. And oftentimes myocarditis is due to viral infections. There can be toxins or drug-induced cardiomyopathies and arrhythmia-induced cardiomyopathies. So cardiomyopathy really just means that there's weakening of the heart muscle. It doesn't really tell you where patients are on the symptom scale. And so when we talk about congestive heart failure, which is more commonly used as terminology, cardiomyopathy can then lead to congestive heart failure. And that's when patients really have symptoms of fluid overload. The heart is a pump. Its function is to pump, receive, and then pump blood and oxygen forward. And so that's where that congestion happens when it can't do that job. And so this is a diagram that actually depicts both a normal heart and then a dilated cardiomyopathy. Dilated meaning the heart enlarges. So when the heart muscle gets weak, it tries to compensate for the weakness by getting bigger, thinking, oh, if I get bigger, I can do more. But that's actually a sign that it's been dealing with this weakness or pressure for a longer time. And that's why people may develop an enlarged heart. And so that can happen on the left side of the heart. That's the kind of the main muscle of the heart that pumps blood forward. It can develop on the right side of the heart, and the muscle walls can become thinner in that setting. So we talked about cardiomyopathy, weakening of the heart muscle. So now let's talk about heart failure. And as a heart failure specialist in the community, we're growing a little bit tired with this terminology. We like to think about being heart function providers and clinicians rather than heart failure. I think it just has a negative connotation, but it doesn't necessarily mean the heart has completely failed. There's a whole spectrum. So it's a clinical syndrome where patients may have current or they may have had past symptoms or signs caused by, again, those structural and functional changes in the heart, which I described already, along with objective evidence of congestion. And we'll talk about what those pieces of evidence may be. And so this is typically what people mean by heart failure. Again, you could be living life, doing your thing, have heart failure, but it doesn't mean that you are on death's end or anything. So it's just a little bit of a misnomer to describe what's going on physiologically. So we like the term cardiomyopathy generally better. So heart failure is common. So if you just take the general population, it's actually the #1 reason for adults to be hospitalized. There are more than 1 million hospitalizations annually for heart failure. And there's a high healthcare utilization and cost associated with heart failure. So there's a lot of resource that goes towards heart failure patients and investment there. And then once someone with heart failure is hospitalized, there's a high chance that that will be a recurrent problem. So let's now put heart failure in the context of ARVC. So with defibrillator therapy, with recognition of causes of sudden death, patients with ARVC are living longer. It's fantastic that we have come so far with ICD therapy, with genetic testing. And so they're therefore at risk for developing some of the other progressive manifestations. And that's why in the last several years, heart failure has gotten a little bit more spotlight in ARVC communities and in clinical practices. So in terms of the phenotypic progression, so phenotype being how does this present? So the thought is that initially it may be concealed, ARVC, and then you enter an electrical stage, as many of you know, characteristic with arrhythmias, and then a structural stage, and that's the progression. And that's where cardiomyopathy kind of rears its head. But I want to highlight that heart failure in ARVC is unique from all the other types of heart failure I just described. So it most commonly affects the right ventricle. So the right ventricle, and I'll actually review this in a minute. Arrhythmias are common, and the medications don't have the same effects or benefits. And it's also rare. So ARVC is rare, and then having heart failure in ARVC is even more rare. So let's talk a little bit about why it's unique in terms of involving the right ventricle. So again, a picture of the normal heart. The left heart is the main pump of the heart. You can see the thicker muscle there. The right side is this kind of crescent shape with a thin ventricle. So blood comes from the body after the body has kind of taken up the oxygen nutrients it needs. It comes over to the right ventricle. The right ventricle is the receiver, and then the distributor to the lungs, where the blood then gets oxygenated again, goes to the left ventricle. The left ventricle is kind of the engine of the heart. It now pumps the blood to the rest of the body. And so you can imagine when your right ventricle in ARVC gets dilated and baggy, the blood flow returns to it, but it gets congested, right? It's a backup to this circuitry. So at Hopkins, we actually looked several years ago now at our registry of patients to see how common is heart failure. So how common are patients describing heart failure? And maybe we're not clinically recognizing it as such. So we uncovered that heart failure it's under-recognized. So when we surveyed 289 patients like yourself who had task force criteria ARVC, 49% actually met criteria for a definition of heart failure. And that is a combination of the structural change in the heart plus the signs or symptoms. So I have leg swelling, or I have shortness of breath, or whatever it is, combined with the structural changes. So a fifth of these patients had biventricular, so meaning right plus the left side of the heart affected. The average ejection fraction on the left side of the heart was 38%. So I always tell patients normal is 55%. So we're not trying to score 100% on this test. I know we're all high achievers and thinking in that way, but be rest assured, 55 to 65% on an echo for your heart function is normal. So 38% is mild to moderately reduced. Our patients that had heart failure experienced it at a median or average age around 41. And it was really a progressive thing, right? So it was, if we looked at when were you diagnosed, when did you develop heart failure? It took 10 years for just a third of the patients to develop heart failure. The rest were further out. Most common symptoms, so dyspnea, meaning shortness of breath, fatigue, which can be nonspecific. And so we actually required one other symptom to kind of meet the definition. Those beta blockers can just by themselves cause fatigue, right? And then volume overload, left-sided symptoms. So that's usually lung congestion, because again, right side goes to the lungs and goes to the left side. If the left side's doing okay, the lungs don't really get congested because blood keeps moving forward from the lungs. So those were rare for patients. And then how could we predict amongst this group, about half developed heart failure, half didn't. So what predicted whether you developed heart failure? Interestingly, females had a little bit higher predominance. I think it's hard to say, because we relied on patients reporting symptoms or their differences in, sex-based differences in presentation to medical management or reporting. Right ventricular dysfunction, not surprisingly, correlated with having heart failure. Patients with a history of hypertension were more likely to have heart failure. And then some of the specific EKG criteria on the task force criteria were associated with heart failure. So I want to talk a little bit more about symptoms. So fatigue, so that can be exercise intolerance, lead to functional limitation, shortness of breath. So there's a couple of different ways that this can be described. We ask about shortness of breath on exertion. Orthopnea is shortness of breath when you're lying flat. That is more of a lung congestion symptom when the left side is not working as well. And in this context, sometimes patients can have these episodes of shortness of breath that wake them from sleep, almost like a panic attack is what patients will describe it as. That's called paroxysmal nocturnal nighttime dyspnea, shortness of breath. Leg swelling or edema, when you can push on your legs and see indentations. Abdominal bloating, so that's not 10 pounds you gained from Christmas. It actually might be fluid. You might have a decreased appetite or nausea in that setting, because all of our organs are dependent on that forward blood flow. And so if the gut isn't getting enough oxygen, or if the tissues in the gut are they're like a sponge, right? So if they have extra fluid, you're not going to feel good when you eat. And then weight gain being, again, fluid related. Weight gain, we tend to gain fluid weight. We can gain fluid weight overnight. Fat and muscle, as hard as you're working at the gym, you're not going to gain that weight overnight. So what might your doctor see? So we look at the neck veins. So if anyone's been to see a cardiologist or heart failure cardiologist, we might have you turn to the side and be staring at your neck. That's because these neck veins, the internal jugular vein, connects directly to the right side of the heart. And it gives us an estimate of how much back pressure or fluid is there on the right side of the heart. We might also see clinical signs of an enlarged right heart. So you might actually feel an RV heave. So the right ventricle, the way the heart sits in the body, the right ventricle is actually the forward-most under the sternum part of the heart. So if it's under pressure if it's under pressure, you can actually feel an RV heave or hear an extra heart sound called an S3. I talked about edema, leg swelling, enlarged liver, again, because fluid can back up to any organ. Ascites is the medical term for fluid in the abdominal cavity. And then a cardiac murmur we can hear if, because of the changes in the right side of the heart, that tricuspid valve gets leaky and has regurgitation. So the next couple of slides, I'll share some of the testing that we do. So pro-BNP, so there's something called natriuretic peptide that increases and elevates in the setting of stress or stretch on the heart chambers. So it's a little non-specific. Arrhythmias can cause it to go up, hypertension can cause it, and also it can be falsely low. So we know patients with normal ejection fraction heart failure, and also obesity is associated with lower proBNP levels. So we always have to kind of interpret it in the context of things. And then kidney and liver function labs. So this can help identify both congestion or low oxygen perfusion to your kidney or liver. In terms of imaging, so echocardiography is something that everyone is probably familiar with getting, or family members are familiar with. We use sound waves to essentially create pictures of the tissue in the heart. And that can tell us about the size of the right ventricle, and ARVC can tell us about that tricuspid regurgitation, and it can tell us the ejection fraction. The other testing we can do is a right heart catheterization. So that's when you come to the catheterization lab and a cardiologist will perform this. It's different than what is more commonly known as a heart cath, where people might be looking for blockages in the arteries in the heart. So this is actually, we put an IV in, usually in the internal jugular vein, just like you would get an IV in your arm. It's a little bigger. And then through that IV that just sits right there, we have a catheter that we can trace through the heart and the different chambers of the heart as depicted here, and measure the pressures as we go through. So we can tell what is the function and the pressure in the right side. How well is the, there's another measurement we can do. We actually inject saline and we can tell there's a thermodilution, there's a transducer at the end that measures temperature. So it measures how quickly the temperature of the blood that it senses at the tip changes. So the higher your cardiac output, the more normal your cardiac output, the quicker that temperature is going to change, because the cold saline is going to go through and change the temperature of the hot blood. The slower your heart is working, the slower that's going to go through. So there's all this math and calculation that goes in the computer based on that, gives you a cardiac output. And then the other thing that we can do is cardiopulmonary exercise testing. So this is testing not for diagnosis of ARVC, more for understanding heart failure symptoms. And so I know that you all have been told to not exercise. We've actually studied this, and patients do very well. It's just a short sprint of exercise, usually on a bike or a treadmill for 5 minutes or so. Can be performed at kind of submaximal levels as well. And it helps to objectively differentiate, is somebody's fatigue and limitation because their heart isn't providing adequate support? In some of our other patients, it can also help distinguish between heart and lungs. And then, or is it physical deconditioning, right? Our patient used to be a swimmer. Now for 2 decades, they've been told no exercise at all when they get on that bike. Is that fatigue, not keeping up with the kids, et cetera? Is that just a function of being on a ton of beta blockers and being told not to exercise? So this test can help differentiate those things, and then also tell us, oh, it is a cardiac limitation. Maybe we should think about further treatment from a cardiomyopathy standpoint. So going back to our swimmer, she was evaluated for heart failure. She underwent the cardiopulmonary exercise test. So it measured her oxygen efficiency. So that peak VO2 number was 11. And I'll just tell you, anything less than 14, we get concerned about. On the right heart catheterization, we measure that cardiac output. So the CI, the cardiac index here, is just its index to body surface area. So, the cardiac output I need is not the same that Shaquille O'Neal needs, right? So it indexes it to your body surface area. So a cardiac index less than 2.2 is low. The right atrial pressure is 14 here, normal is closer to 5. So this is a heart that is under stress from the right side. And so our patient in this context and her symptoms was ultimately admitted to the hospital after medications as an outpatient were not relieving. So what are the medications we have? So diuretics are the mainstay. Diuretics are simply fluid pills. So they help help you pee off that extra fluid and get that fluid to the kidneys so that it can offload the heart. So these are the common ones used. Fluid and sodium restrictions help too, right? The less we put in, sodium causes us to retain fluid. Even in folks who don't have heart failure, we'll notice after a heavy salty meal, maybe they have some ankle swelling. So, following those restrictions usually helps with not needing as much diuretic. If the left ventricle is involved, we have really good evidence-based guidelines for 4-pillar therapy. So 4 medications. I've listed the classes here. No reason to kind of memorize these. There's different medications that can be used in each of these categories. And then if only the right ventricle is involved, we do use some of these medications a little bit more cautiously. Just the physiology is a little different of the right ventricle, as I've hinted at, and so they don't have as much of a benefit necessarily. All right, so in addition, some of the other key things to highlight in terms of treatment is more preventing disease progression. So exercise restriction helps from a heart failure standpoint too, as far as we know, just like from an arrhythmia standpoint. And then controlling the arrhythmias helps. If folks are getting shocked more, having more arrhythmias, that can make the heart sicker, or the cardiomyopathy sicker. So I talked about the fluid restrictions. This is a handout we give to our hospitalized patients or in heart failure clinic patients. It's kind of the heart failure. At some point it was a simple 6, but looks like 7 here. So some of the keys are 2-liter fluid restriction, and this does not apply to everyone with ARVC, just to clarify. It's really only if your doctors recommend it, if you have been struggling with heart failure and fluid overload. Of course, taking medications, weighing yourself daily. Again, as I mentioned, that weight gain overnight in someone who has heart failure in the setting of ARVC is going to be indicative of maybe needing a little extra diuretic and heart failure control. Limiting salt, appointments, physical activity to the limitation that we do in ARVC, and controlling other risk factors like smoking cessation, blood pressure control, et cetera. Okay, so I'm going to move with the next few minutes to, what do we do if we've tried the medications and someone's just really struggling with heart failure? Their kidneys are starting to get angry about it, and their liver and stuff. And so in terms of device therapies, so they're less readily available for the right ventricle, but we've made a lot of headway in the last decade. They're usually temporary, so they serve as a bridge to more definitive treatment. And what I mean by that is usually transplant. And they require patients to be in the hospital. So just like I described that right heart catheterization that we do, that same kind of source of access, we can deploy pumps and various devices that help the heart work more strongly, all the way to full heart support on something called ECMO. So when do we think about heart transplant? So there are a couple of different indications, and heart failure is not the only indication. So really intractable arrhythmias, and this is not specific to ARVC either. This is just kind of all indications for heart transplant in the broader sense for heart failure. Right-sided heart failure, left-sided heart failure, again, significant symptoms despite maximal therapy, needing IV medications to increase pumping in the heart, needing mechanical devices for blood flow. In all those situations, we're thinking about a heart transplant. And for anyone I've met in clinic, you've heard me say, the timing wise, we like to think about this early. It never hurts to think about it early, because the healthier the rest of your body is going into transplant, the healthier it'll be coming out. And so we say, sick enough, but not too sick. So timely recognition of heart failure, especially because it can be a little more atypical in ARVC, is important. And that's why some of our objective testing is also important to kind of distinguish, well, is it that sotalol, or is my heart just not pumping as well? Is that why I'm tired? So what does the process look like if we are thinking about heart transplant? So it's a multidisciplinary evaluation. And so it's kind of a head to toe evaluation. There are pretty strict inclusion and exclusion criteria. And this goes for any center really. In terms of testing, like I mentioned, some of the things we will do right heart catheterization and metabolic stress testing. And then there is the national registry or national platform, the United Network for Organ Sharing, where you go in as on the wait list, and you can be at home on the wait list. Again, if we start this process early, and if you get sicker, then you might be admitted to the hospital. And so this is a figure one of my colleagues, Paul Shield, put together. And it's kind of our approach to transplant and ARVC. So you've made the diagnosis and, made the diagnosis, and maybe someone has more of an arrhythmia presentation, managing that. But if they have recurrent arrhythmias, worsening heart failure, or symptomatic heart failure in that setting, you've gone to the heart failure presentation box, where you're being evaluated by a specialist, getting comprehensive heart failure assessment. We talked about, so GDMT stands for guideline directed medical therapy. Those are the different pillars of medications we have. Diuretics, following echoes, considering the exercise test. And then if we progress, then we think about a right heart catheterization and heart transplant evaluation. And if someone has primarily right-sided dysfunction, they might be in the hospital just sick and not requiring necessarily any invasive devices or anything, but these are some strategies that we use. So inotropes or IV medications that can help in the short term, help the squeeze of the heart and blood flow to the rest of the body. The downside of them is they are kind of whipping the heart into working harder, and that can be more arrhythmia driving. So in an ARVC, we have to, of course, be careful of that. And then if you have more of a left-sided phenotype, so it's the left ventricle, then we have more traditional strategies that we use more widely. So these are just the heart transplant numbers in general from the national registry. So you can see it's about at 3,500 heart transplants a year, somewhat stagnant over the last couple of years. So of course, this is a scarce commodity. We looked at specifically for the indication of ARVC, what are the numbers like? And you can see that every year, generally speaking, the number of transplants for ARVC have gone up. That probably is not because our patients are doing worse, but because we're recognizing ARVC as a diagnosis earlier. We're intervening, right? And patients are getting advice to back off on exercise to prevent arrhythmia, getting ICDs, there's family cascade screening. And so then patients are living longer and developing that downstream heart failure. In terms of heart failure in general, generally 1 year survival is 90%. Median patients are, with their hearts for 14, 15 years. So it really does add a significant portion to patients who might otherwise have very limited survival within that 1 year, even after transplant. So you're on a lot of new medications, namely immunosuppression to help prevent rejection. We do biopsies and other blood work to monitor for rejection as well. And then there's some other medical things, side effects that can come up and that we just help control afterwards. So some of the medications can actually cause hypertension. And so I often have surprised patients who are used to walking around with a blood pressure of 90 over something, who now have a blood pressure of 140 over something post-transplant. That is just that heart's banging away, plus some of the medications, plus some effects that increase the blood pressure, and they're on medication for that. So in summary, heart transplant and ARVC is a great option if you need it. There's no evidence of recurrence in the new heart. And so, for those who are eligible, just a call to encourage folks that to be organ donors, because that's really what it relies on. So back to our patient, she underwent a heart transplant evaluation. She was waitlisted in the hospital and underwent transplant successfully within a few weeks. And now, several years later, she's back to working full time and being active with her kiddos and family. So in conclusion, heart failure can be seen in ARVC. Monitor for signs and symptoms such as shortness of breath, leg swelling, and abdominal bloating. The main treatment for symptoms is diuretics. And though I spent a significant portion of the talk talking about heart transplant, it is very rare. So very rarely patients can benefit from evaluation and need for heart transplantation. Just want to thank our ARVC team at Hopkins and thank all of our patients and their families, without whom we really wouldn't be where we are in this field. I'm happy to take any questions.
Thank you very much, Dr. Gilotra. So I'd like to ask anyone who is interested in asking a question, you may either put your question into our chat field and we'll address those, or you can like raise your hand and you can unmute yourself and ask your question verbally, whatever your preference is. Okay, Bob has raised his hand, so you need to unmute yourself, Bob.
All right, I was going to put it in the chat field, but I can't find it.
Okay.
Age limit for heart transplantation.
So that is center dependent. For us, it's 70, 71. There's a couple centers that go past that, but not a lot.
All right. And then one of your posters had exercise restriction. I fully buy into the Calkins restrictions from Hopkins. Is that apply for heart failure as well, or would it be more restrictive or less restrictive?
Yeah, so heart failure, so I would say less restrictive, but I think we're just learning about kind of the disease progression, right? So there's a lot of data in terms of the arrhythmia and changes in the ventricle with exercise. How much that kind of translates into symptoms with heart failure, we haven't really looked at as a field. But in general, if exercise is going to, heart failure is a consequence of the structural progression of ARVC. So whatever can halt that structural progression will help halt downstream heart failure.
Okay, but it wouldn't be more restrictive than the restrictions on ARVD exercise. Okay,
no.
All right, there's some good news there.
Okay, thank you, Bob, for your question.
Thank
we have
you.
a couple coming in from the chat field. One is, are saunas okay for ARVC folks?
So, so that question, it depends a little bit clinically. So, hot environments are going to vasodilate and actually the blood vessels. And so actually sometimes folks with right ventricular dysfunction don't do well with that. So that's also why some of the medications that we use with left ventricular dysfunction, where we actually want to vasodilate because that takes the load off of that left ventricle so it can push forward blood. That actually, the issue then is that the right ventricle, if the right ventricle is weak, it can't then fill the left ventricle. So you've helped the left ventricle empty, right? But if the right ventricle can't fill the left ventricle, now the left ventricle is empty and you're at risk of passing out, basically, and getting dehydrated. So I would be careful.
Okay, thank you. Another question in our chat. What % of ARVC patients have a pacemaker? This person had Mike and or Christy had one placed with my AICD as my heart rate was 30.
Great question. So it's rare actually for ARVC itself to cause conduction issues. It can often we can often use that to kind of distinguish different conditions that we might suspect with some overlap with ARVC. Now, I will say a lot of the medications that we use to control arrhythmias can slow the heart rate too. And so if you're going to need to be on those medications, your doctors might say, well, the benefit of being on those medications is you don't go into sudden cardiac death from those arrhythmias, but we're going to need a backup pacemaker to help the heart from not going too slow. And to clarify also, every ICD, every transvenous ICD, not subcutaneous, but every transvenous ICD that's implanted here has a backup pacemaker in it. So oftentimes it's not that it's a second device or something that's being placed, but it actually it's the nature of the device, because it has to have that, because if someone has VT and they're shocked, that stunning of the heart, it can take a few seconds to wake up. And so that pacemaker can be there to do that backup pacing in that time.
Okay, thank you. We have a hand raised from Shasi. Deb, would you like to ask your question verbally?
Yes, thank you. It's Shashi, but thank you. So I have a couple of questions. The first one is I don't know if you have data on this, and maybe you said it and I missed it. What percentage of patients with ARVC actually develop heart failure or symptoms of heart failure? And then maybe tie that back to, I saw in your data that there's a progression of heart transplants that have been taking place over the years. What accounts for the increase in heart transplants that are taking place, the rise of that?
Great question. So, when we talk about heart failure symptomology, so I will say that the limitation is symptoms are subjective, right? And so we're not doing invasive or stress testing in everyone, but in our cohort, we found that that almost 50% of patients had some heart failure symptoms. The question about transplant, so a couple of theories. One is that patients are outliving sudden cardiac death, right? And so they then are going on to develop cardiomyopathy and the downstream effects of cardiomyopathy. And then the second is just improved recognition. So the way that these transplant registries work in terms of the data, the diagnosis is based on what's entered from the transplant center in terms of the transplant diagnosis. And it's actually a fault is that it's the pre-transplant diagnosis and not the confirmed diagnosis once the heart's out and we can see what it looks like once the patient's been transplanted. And so we have to take that with a little bit of a grain of salt, but it's probably that clinicians are increasingly recognizing ARVC as a diagnosis. And so they're able to say this is ARVC rather than this is a right-sided cardiomyopathy, not otherwise specified.
Okay, and then one other question. How often, when you talked about symptoms and criteria, which I kind of look at as a little bit different. So I'm going to use myself as an example. I'm asymptomatic for the things that you mentioned, but I have a lot of the criteria. So I have high BNP, I have severe tricuspid regurgitation, and some other host of criteria, but I don't have any of the symptoms. And I've had a right heart cath. I've done a lot of the tests that you identified and measured. So I'm doing a diuretic. I'm taking also Entresto. I'm on cocktail medications to kind of see whether the BNP can go down. Yep. It seems like that there's a whole cohort of patients that are in the same category that I'm. I don't know if this is true or not, and can kind of coast along for a while in the situation without having to have interventions.
Yes. So again, we talked about transplant, but that is rare, right? So I can pull up that slide again to give folks a sense, but give me just a second here. The medications that you're on are helping with that, right? So that's the whole goal of those medications, is to keep patients asymptomatic and kind of catch things early. So in heart failure in general, especially left-sided heart failure, there's indications for medications even before patients are symptomatic, right? So the point of those is to kind of reverse remodel the heart and prevent progression and to reaching the point of symptoms. So again, it's very manageable if we can kind of intervene early. So in the whole, just to give you a sense of the numbers, in the whole cohort we looked all the way to 1994, it's like 150, 160 heart transplants. And so in the last 4 or 5 years, there have been about 100 patients that have been transplanted for ARVC. And this is out of 30,000 patients.
Thank you.
Okay, thank you. Doug has a question in the chat. If one does not exercise because of ARVC and one is 75 years old, does the patient run the risk of having muscular atrophy problems? Does losing muscle mass in the senior years increase?
So that's a great question. So, just because we can't exercise in that true kind of form of exercise, doesn't mean we can't stay active, right? So walking, light reps of activity that can maintain muscle mass is totally fine. I'm not aware of any studies specifically in ARVC patients in terms of the impact of not exercising on other factors that you bring up, like muscle energetics, for example. But it's a really interesting question.
Okay, and Robert Ramirez has his hand raised. Robert, would you like to verbally ask your question?
Yeah, if you don't mind. First of all, thank you guys for putting on this webinar. I actually have 2 questions. The first one is, so my sister, actually both of my sisters have ARVC, along with me. So the 3 of us have it. My youngest sister had a heart transplant at the age of 25 because of heart failure. So looking at averages, from what we hear, she's got about 15 to 20 years. We're kind of, taking in that fact, but the question is, what are her options, 15 years from now? If she I know she doesn't have ARVC with the new heart, but
Yeah.
Are there any options for her after that 15, 20 years from now?
Yeah. So the question is what end up being the morbidities down the road. And so most common, so we have had patients who what we'll see at that stage is kidney dysfunction. So patients might end up on dialysis just because of the long-term effects of some of the medications, but then they could be eligible for a kidney transplant. I know easier said than done, but that happens not uncommonly. The other thing that can happen is that patients can develop what we call coronary allograft vasculopathy. So the blood vessels in the heart kind of remodel. It's not the same entirely as cholesterol buildup and plaque buildup in people who have heart attacks, but it's similar fashion where the blood vessels can essentially narrow, and it's thought that kind of chronic slow rejection can lead to that. And with that, then patients can develop a more stiff heart, and that can lead to heart failure symptoms again. But the good news is that in younger patients that they're actually retransplantable. I know it sounds crazy to go through a second heart transplant, but it's definitely doable. And that is I think that's the answer to in terms of what are the options at that point.
Okay, that's great. Yeah, that was one of the biggest questions that we had, was whether she would be retransplantable and what her eligibility was. And
yeah,
the second,
and it depends on what else is going on too, right? Just like with the initial transplant, I'm sure she went through a slew of testing and kind of evaluating, and so that would all happen again.
Thank you. And the second question, if you don't mind, so my wife and I are expecting, and we're looking to do keeping the cord, the blood cord and like the blood, kind of all that stuff. I know there's been a lot of studies out with stem cell research, kind of helping out with certain organs and just different body parts. Is a heart one of them that you know of? So like if we do end up keeping the stem cells, and then either myself or, maybe one of my kids down the line have heart failure, is that something that might be able to help? Do you know of any studies that have shown that there is an improvement in heart failure with stem cells research? So
there are some studies in stem cell research and kind of regeneration. It's ischemic cardiomyopathy, so coronary disease as well. Not specific to ARVC, but the field is kind of heading towards a gene therapy approach. So I think a lot of evolving things, but nothing that's out there just yet.
Thank you
Okay.
so much.
Thank you, Robert. All right, a question from Michelle. What about bendopnea?
So bendopnea is another heart failure symptom that's been recently described by some of my colleagues at University of Texas Southwestern. So it's the sensation of when you bend over, feeling short of breath. Just like when you lie back, you might feel short of breath because those lungs fill up with fluid because you don't have gravity working in your favor. Now you're bending over and the fluid is going this way and causing shortness of breath. So that's what bendopnea is, and it is a heart failure symptom. It's less common again in ARVC because it's less of a right-sided heart symptom.
Okay, thank you. Marilyn asks, what about treating with Jardiance?
Great question. So Jardiance is one of our newer medications in terms of its heart failure benefits. So this is so empagliflozin, dapagliflozin. They're two diabetes medications that have been around for a long time. And some of the secondary studies where they were actually looking to make sure that there wasn't an adverse cardiac safety signal, they discovered there was a positive signal. So it actually improved cardiac outcomes kind of across the board. So then more recently, they did studies specifically in diabetics with heart failure, and then in just heart failure, non-diabetics, and found improved outcomes. So reduced hospitalizations, increased survival, several different cardiac outcomes. And so that has become, I mentioned those 4 pillars of treatment, that has become that 4th pillar. And so the data for that really is still in the left-sided heart failure patients. There's no data on with right-sided heart failure patients. So it's you know, I think the jury is out there, but sometimes we extrapolate what we have. And I see a related question about Entresto and spironolactone. Same thing with those. They have, and some of you may have left-sided heart failure too. So I just want to be mindful of how I'm answering the question, right? So your physicians might have you on these medications because of a combined right and left or left predominant cardiomyopathy. And so certainly they're absolutely fantastic medications for those indications. For primarily right-sided, we will start medications related to Entresto if blood pressure, et cetera, can tolerate it. And then spironolactone doesn't hurt in right-sided cardiomyopathy because its effect is basically to try to decrease fibrosis, but it also boosts potassium levels. So if you're on a diuretic, you might be familiar with the fact that diuretics can deplete your potassium levels, and also we like to have potassium up because low potassium levels can make the heart more prone to arrhythmias. So spironolactone kind of has that added benefit. You don't have to take those potassium horse pills. You get a medication that keeps the potassium up while you're on a diuretic, plus has some anti-scarring and anti-fibrosis effects.
Thank you. Let's see. Sean notes, asks if you're familiar with Dr. Doris Taylor's work in heart transplant research, replacing the heart cells with their own stem cells.
I'm not.
Okay.
But I think kind of going along with the previous question about stem cell research.
Mm-hmm. Okay, let's see. Oh, Patrice just made a comment. I wish I had this presentation show my family and friends prior to my transplant so they would understand what was going on. And I am 9 weeks out from transplant and doing really well. And Patrice, this is being recorded so you can share it afterwards. No problem with your family and friends. Steve asks, is there an acceptable heart rate for cardio exercise?
So that question I'll defer to your individual physicians because it really depends on your arrhythmia history, what your ICD settings are, and everything, because we do want to prevent arrhythmia and shocks unnecessarily.
Okay, are there any other questions that you'd like to put into the chat? We'll address those, or anyone want to raise their hand? I don't see any more hands at the moment. Sean noted that the study was on CNN. He's going to attach the link in the chat. There it is. Okay. About the heart transplant research and stem cells. Okay. Thank you for putting that there. All right. Well, with no more questions or comments, I'd like to thank you, Dr. Nisha Gilotra, for your time tonight. And I would also like to thank all of you for attending. And I wanted to remind you of our second webinar with patient perspective.
I had one other question.
Oh, go ahead.
Sorry. So my wife has tricuspid regurgitation in addition to ARVD, and just trying to figure out if those are separate things or are usually interlinked.
They're usually interlinked. So usually it's due to the right ventricle being dilated over time. So when it dilates, the valve leaflets are together. When it dilates, they separate. And so that allows for that leaky heart valve.
And how would you try to treat kind of tricuspid regurgitation that's getting more severe?
So at one extreme, there's surgery, but really that's kind of a last resort. Oftentimes people handle it just fine. It really depends on symptoms. So, you know, if symptoms are well controlled, then there isn't an indication to intervene on it.
Thank you.
Can I ask a question too? I'm not sure if can you hear me? Oh,
Yep.
oh, I can, okay, sweet. Sorry.
Yes,
Sorry.
go right ahead. I was sorry, I was muted.
Thank you. So I just had a question. One, thank you so much for doing this. Like, I learned so much from these presentations, and I always end up learning more than I think I'm going to, and I'm so grateful. So thank you. But I also just wanted to ask, so are you seeing any, and I don't know if anyone's looked at this, but any links between the genetic type that the gene mutation that has led someone to ARVC? Is there any correlation you're seeing with those that develop CHF and those who don't?
So there's definitely correlations with those who develop left-sided cardiomyopathy versus not. You know, in our cohorts, they're generally small to be able to say that someone with a certain mutation is more likely to develop heart failure per se, but certainly different genotypes are associated with different phenotypes in terms of disease progression. And so I'd say anything that's already out there in that regard then goes hand in hand just with the kind of the longer term risk of progression to heart failure.
Okay, that makes sense. Thank you so much.
Mm-hmm.
All right. Thank you all for joining. And as I want to remind everyone and encourage you to register for our next webinar. It's on next Thursday evening, June 16th, where we'll hear perspectives from 3 patients living with ARVC and heart failure. So thank you for joining, and we hope to see you soon. Appreciate it. Have a good rest of the evening.